Session number 4. Let's discuss the most underrated team. The most underrated team in most physician practices and how training them on care gap booking can help your practice close care gaps faster, earn millions of dollars in quality incentives, and improve your quality score. My name is Maruk and I help practices close care gaps, earn incentives, and improve quality score. This is the last session of the 4-part series on how to actually close care gaps and earn incentives.
Oh, look, session 4 is all about us. Guess we finally matter. What? A new care gap booking list? I need a break.
The fourth most important step to maximizing quality incentives is train your booking team. Train your patient engagement team. And should I go ahead and disclose something more than that? Well, I think I should say it. Booking team working usually from Southeast Asia, serving your patients across time zones on low wages, patiently taking your provider's tantrums like a partner who never leaves.
You can't say that out loud. Us being exploitative, that's internal policy, not public knowledge.
Careful! Calling us exploitative is against company culture. On paper, we're a family.
I think we should start without giving away any personal details on how some clinics actually operate, because I'm a bit afraid right now. I better watch out what I say, right? Let's keep going. Let's forget what I said on this slide. Now, this is a professional question related to care gap and incentive. That's a fair question. Who is taking the blame in your clinic? Who is taking the blame in your clinic for lost incentive and missed care gaps? And if your response is booking team, then we will see in this session who to hold accountable based on your audited care gap data. And by the way, it is not always the patient engagement team, because we will hold right people, departments accountable who are actually responsible for open gaps. Okay? I have seen clinics make these mistakes over and over again, and we will discuss about these mistakes. These are the things which you should not do with your patient engagement teams, right? So you do the following things, which is handing out a giant list of patients with care gaps, and you tell them, call them all, I need them all booked. Blaming booking teams when gaps are missed, even if providers ignored them. There are no scripts, no context, no training, just wing it kind of approach. Then treating booking staff as replaceable, low-paid labor instead of strategic partners. And these are the things which are happening in most of the clinics. Here is the point. Hold right people accountable. If providers are missing care gaps, they should be held accountable. If claim and billing is not using payer-recommended CPT codes that can easily earn quality incentives, then claim billing, those departments should be asked why they are not using payer-recommended quality codes. And if patient engagement is not able to book care gap patients, they should be asked why, and specifically mention the reason in the comment column of the care gap booking list regarding the outcome of reaching out to the patients. That is, whether a patient already has a PCP, refused right away, the patient changed insurance, and there can be so many reasons. Knowing the reason will help your practice with elimination. such that patient engagement is not wasting hours in reaching out to uninterested candidates. And hey, if patients have refused to book, then stop taking that all out on patient engagement teams. Stop taking out your frustrations on them. Accept rejection and focus on interested members. And most importantly, send your quality folks to negotiate with pairs and see if you can replace uninterested, inactive, invalid members with interested, active, valid members. That's a much better and sensible approach rather than, crying like a child over a few patients the practice is unable to schedule a visit with. And additionally, the thing which I have noticed a lot, saying things like providers are our bread and butter and we can't hold them accountable, which a lot of clinics, yeah, that is their perception. This kind of perception won't help your practice and you will never be able to earn incentive with such excuses, right? A lot of you are saying, we don't have a booking team. We have some outreach software or automation in place. Well, then that means now you can finally hold relevant people accountable because you don't hire patient engagement teams, or well, not in as much volume as you used to due to automated outreach in place. So, anyways, I have already made myself clear. Know who to hold accountable. The reality is that in many clinics, booking teams do everything with zero training and they also take the blame. And this is specifically true for care gap bookings. So most clinics, they will have a patient engagement specialist or a lead patient care coordinator who is downloading all these care gap lists from provider portals such as Healthfirst, Dallas, etc. And without auditing care gap lists, this lead care coordinator gives lists to patient engagement or booking team. And the naive, untrained, unguided booking team sets out to book a patient who already completed cervical cancer screening last year. And so imagine what happens when such a patient shows up again and provider finds out that the care gap screening was already done last year. Ouch. Well, that is a messy situation. And it actually happened at a clinic. Yeah, it did happen at a clinic, and the provider was very angry because the visit reason was care gap screening. And the screening was already done. So, an untrained team wasted its own time, patient's time, and provider's time by booking a care gap patient who already performed a screening last year, which was still valid. So, what you have to understand here is that booking teams are your bread and butter because they are the first line of communication with patients, especially true for new members, right? And if the patient engagement is not guided on what to say to these patients and they keep booking patients with closed gaps due to unaudited lists you are handing out to them, then there will be no incentive. It's like running on a treadmill that's going nowhere. Poorly trained teams, they will bring in overwhelmed, annoyed, and disengaged patients who will soon get off the panel. Yeah, patient can do that. They can call the insurance and say, hey, we want to change our PCP. We don't want to be we don't want to be with this practice, or we don't want this practice as our PCP. The reason I mentioned overwhelmed patients is because I remember a patient from a practice once told that he was getting 5 to 6 calls every week from the same clinic. And I was like, wow, I wish someone could make me feel that important as well. So stop calling your patients as if you are calling at your grandma's home, right? It is not your grandma's home, it is your patient. Treat them like a patient. And obviously, you will never have a trained booking team if you keep replacing them. and ghosting them, which is very true, and I have seen it a lot happening these days due to automated platforms. So the point is that trained teams equals smoother patient experience, closed care gaps, higher quality scores, and incentives flow when engagement is strategic, not random. So I remember I was, working at a clinic, and she was asking questions from the patient engagement team, and someone from the patient engagement team responded that providers are not doing those care gaps, right? So the CEO said, providers are our bread and butter, and something along the lines that we cannot upset them. Hey, you see, bread and butter still has to do the job. If providers skip care gaps on the chart, no booking team can fix that. Being a provider does not excuse you from doing what you are supposed to do. And also, just because your patient engagement team is replaceable or as is what you assume, does not give your practice or any practice the license to not train the booking team on care gap or treat them as less of a human. So the point is that stop punishing patient engagement teams for systemic failures, right? Train and support them instead. We will see the right way to booking, right? Because you want to book smart, right? So we will do these two things to guide and train booking team on care gaps. Number one, we will give them audited care gap lists. And number two, you will provide them customized scripts. And if you cannot provide them customized scripts, you at least inform them that, hey, this insurance is offering rewards if the patients complete certain screenings. And so how about if we can incorporate that information in the messages or the campaigns that we are sending out to the patients to complete their preventative screenings? Because everyone is getting reward. Clinic is getting incentive, payer is, charging these high premium fees. What is the patient getting? Yeah, they are healthy, but the patient is like, hey, no, where is our reward? So this is your chance to tell them that, hey, no, you also can have financial rewards if you complete your preventive screenings. Now, this is something about auditing that I want to talk in detail. I did not mention how to audit in the first session because that could get a little bit complex. But here we will discuss a little bit about how to audit because this will allow us to hold right people accountable. Auditing is important. Giving audited lists to patient engagement teams is even more crucial. You are saying that, hey, what do you mean? Are we going to audit 1,000+ members on our care gap list to see whether they actually need care gap booking or not? That's quite a task. If you know how to audit care gap lists, then you can do automation as well, right? So this is just a blueprint. It is up to you now whether you want to do manual or automated. And based on your, let's say someone automates it, then based on your automation, you should be able to label each patient into one of the following categories that you see in front of you. As mentioned in session 1, the lists are not accurate. Okay, the care gap lists are not accurate. They need a lot of cleaning. So every member that you see on the care gap list, one of the following things is going on with that member, right? So these are kind of statuses. And one of these things is going on with the member listed on your care gap list. Number one, either they need screening, which means that they never did the screening, and if they did it, their screening is no longer valid. And so in that case, you label that patient as pending and open gap, right? Now, another status that you can assign to members is when they have already scheduled a visit, right? So let's say there was a member on my care gap list, but when I checked in the EHR, I saw that this patient is already scheduled. So this is good. What I can do is, instead of again reaching out to the patient and overwhelming the patient, I can populate their chart in the EHR with care gaps so the provider knows that this patient has these care gaps, and the provider knows that he has or she has to close them, right? So this is another status. Another status is, let's say that someone from the booking team scheduled the patient, right? Let's say the patient had open gap status and the booking team was like, okay, we should go ahead and schedule the patient. And the booking team scheduled the patient, but they did not show up, or they showed, but the provider missed the care gaps on the chart. In that case, you can label that patient as recapture. Another status which can be assigned to the patient on the list, on the care gap list, is the booking team, they called the patient, they offered the care gap screening, they offered preventive screening, but the patient refused. Patient refused any type of visit or any type of screening. And then in that case, you can label that patient as patient refused, right? Another case is that the booking team tried to reach out to the patient based on the information that they had, but the number is invalid or the member is inactive when you check their eligibility. And so in this case, you have to mention that the number is invalid, or the patient data is incomplete, or it is inaccurate. Okay, so this is what you can label that member. And this is very important. The color scheme that you see here, it is very important because we are going to categorize and assign to the right departments these statuses. Another case can be, which is, the ideal case, which we are always looking for when it comes to care gap, is that, you scheduled a patient completed the visit, and the care gap is closed, and you label that patient visit completed, gap closed, so that no one is bugging that patient on care gap screening because they completed it, right? And another status is supplemental done, because a lot of measures require supplemental to be done to be able to earn incentive, right? So for example, if I have a patient and I saw that they already completed their depression screening, but to be able to earn incentive, I have to do supplemental as well. So for that measure, my next status would be supplemental done. And when I have submitted that file, I will change the status to supplemental done. Okay, so this is very important. Whether you are doing it manually, whether you are doing it through automation, at any point, one of the following statuses must be assigned to a patient in your care gap list. And these will keep changing, right? So, and this is happening on daily basis, right? Because when you are scheduling a patient, the patient is scheduled, let's say for tomorrow. Let's say a patient had, status scheduled, and tomorrow is their appointment date. And so tomorrow, when I will come back and look at those who are scheduled for today, then I will see at the end of the day whether those who were scheduled or who had the status scheduled, did they come or not? And if not, these statuses will change accordingly, right? So this is the blueprint. Whether you do it manually, whether you automate it, That is up to you. Okay. But the idea was to tell you how to audit the care gap data. You cannot leave, you know, the members and just blindly give the list to the patient engagement team, because the patient engagement will keep scheduling patients who have already closed gaps, and that will be a lot of mess, right? So let's move on and see how this categorization is going to help us further. So, based on the different statuses that are assigned to patient or members on care gap lists, we can better decide as a practice who is responsible for what. Example, the booking team is responsible to book any patients with pending or open gaps, and also recapturing patients on care gap list that either missed screening or they did not show up. So in short, the booking team is responsible for changing the status of a member from open gap and recapture status to scheduled status. Understand what I'm trying to say? The booking team is responsible for changing the status of a member from open gap and recapture status to scheduled status. That is their task. That is their responsibility. Now, what about other statuses where, let's say, that patient had open gap status and booking team reached, but the booking team faced issues like invalid numbers, changed insurance, inactive members, refused members. Now, if these are the statuses which I have added in red bucket, right? Which I have added in red bucket, if these are the statuses, then booking can't do anything. If the insurance is not ensuring data accuracy and completeness, then booking can't do anything. So what's the solution? What should we do with all the members if they have any status from the red bucket? Can we leave them? Because that is an incentive. Yes, we have to eliminate them, but be smart. This is the bucket when quality specialist in your clinic will discuss all such cases with the insurance in quality meetings specific to your practice and negotiate replacement with different members who are alive, have active eligibility, and have valid numbers, and who do not already have a PCP, right? See what I'm saying? That is how you decide which team in your clinic is responsible for which members on your audited care gap lists based on their status that you assigned them. And obviously, if you are actually a quality expert, you would want to and you should mention the outcomes of your efforts in closing care gaps by giving the upper management or CEO a concrete number on closed gaps and supplementals done. And based on these two statuses in the blue bucket, you can exactly give them the dollar value earned so far. Now, let's imagine a scenario where the patient engagement team is working with unaudited care gap lists downloaded straight from the provider portal, and you tell them to book all the patients on the list. Patient engagement teams usually have no in-depth knowledge on clinical measures, and they might not know whether a patient on the care gap list actually needs a screening. If you will give them unaudited lists, there is a high chance that they will schedule patients with care gaps already closed. And I have seen this a lot in small to medium-sized practices where outreach team did not check patient records before booking. They did not check the EMR records to see if the colonoscopy was already done. They did not know that colonoscopy is valid for 10 years, so they just scheduled patient for preventive screening. And when the patient shows up on the appointment date, both the provider and patients are angry because nothing is pending. All screenings on care gap lists are done and are still valid. This is the reason we audit. This is the reason that we audit. And that is why the session 1, the complete session 1 was dedicated to auditing. So to stop overwhelming the patient engagement, we do auditing. We strategically assign members to right people and right departments. Okay? So I might show you the audited lists to give you an idea that how auditing is done and how the lists are prioritized. So look at this Healthfirst list that I have. And on the left, we have actual members, which I obviously do not want to show you because it's patient's data. So look at this measure and look at the statuses. The point is, I want to show you the statuses and how the lists are audited. Look at all these statuses. They are similar statuses that I mentioned to you. And these lists are being audited. And look at the comment column. So this patient engagement team is not reaching out to the patient mindlessly. They are getting audited lists, and based on the audited lists, they are reaching out to the patient, right? And then look at this list from Catholic that we got, and this has different pairs. So we are getting care gaps for Health Plus, for Cigna, Aetna, and Humana as well. And again, see here, the patient engagement team is adding their own comments, right? And we have statuses here. Look at these statuses. Okay, so there are different statuses here. And again, this is Wellcare and Fidelis list. And again, you can see here that we have statuses. These patients are assigned statuses, and only after a certain status, the patients are assigned to certain members in a department. So if the status is pending or open gap, or the patient needs recapture, then it goes to booking team, right? And if not, then it goes to a quality specialist so that they can discuss all such cases with the quality manager, insurance quality manager, and see if replacement of members is possible, of those members who are uninterested, who have refused the screenings. Yeah, so it is important that we do that. And this is how the lists are audited. So this in front of you, I showed you a practice who was actually auditing their lists and were strategically reaching out to patients. So now we will discuss about the second thing which you need to do as a practice in order to guide or inform your booking team, which is providing them customized scripts. Or if you cannot provide them with customized scripts, you should mention that there are rewards for certain screenings from certain payers or insurers. Because payers, they do reward members or patients for staying healthy. And if you are not sure whether certain insurance has any rewards or not, you should type this in, search, Google search, and you will be able to see what type of rewards there are available and for what plan, right? Search pair name, for example, Fidelis plus member rewards, and it will take you to the member rewards page, right? And then based on that information, you can adjust outreach scripts accordingly. And sometimes you can also keep reward forms in clinic if possible, right? If it is possible, you can keep the reward forms in clinic as well, so that when a patient visits, they have done their screening, you can give them the reward form and you can guide them on how to, whether they have to download an app or whatever they have to do to be able to earn that reward. So guide your patients on how to get rewards and help patients as well to earn financial incentive. And now this looks more equal. You are getting incentive, they are getting incentive, everybody's happy. So let me show you some pairs and their reward forms, right? So you can incorporate those into your scripts, and the patient engagement is rightly guided on how to reach out to the patients, right? So let me show you right now. So here we have health first, right? It is saying staying healthy has its rewards, okay? By completing preventive screenings and tests, qualifying Healthfirst Medicare Advantage plan members can earn reward cards that can be used at these participating stores: Bath and Body Works, CVS, Foot Locker, and let's go down. So this is the step, right? These are the steps that the patient will need to do after they've completed their screening, and they will be able to finally activate their card and start shopping. Let's go down and see. So this is the form. Fill out one of the one form for each qualifying member. So you see, this is complete information. Preventive screenings, qualifying health services. So, there is a word for breast cancer screening, and there is a word for colonoscopy. Wow, so these are all the screenings that clinics have a lot of challenge, right? Because patients either refuse them right away and they say we already got it done, but when we check the record, it's not done or it's not valid, even if it was done. So I think that this is really helpful. And let's see for what other plan do they have. So here they have rewards for people with Child Health Plus plan or who are Medicaid members. Wow. So this is also really good. Annual dental visit, 6 well child visits. Okay. So if you tell your patient about these rewards that they can get on completing the screenings, you can improve your booking rate. And here again, you see that if someone can qualify for this personal wellness rewards, so if someone has this plan, personal wellness plan, then these members can also get a reward. And these are the things that they can get a reward on. So the fact that it includes these screenings, which are really challenging for the clinics, is really good that they added all those challenging screenings in this reward form, where you have to keep waiting for the patient and you have to keep reminding them. It's really hard, particularly for these screenings, which is cervical cancer screening, colorectal cancer screening, breast cancer screening. So these 3 or 4 screenings, they become really hard sometimes. You see here we have compiled the plan name, the screening, and how much reward that screening earns, right? So the reason I put it here is to make it easier for everyone involved with me in this process of care gap, to make it easy for them to see what kind of rewards and what is the amount and what plan on what plan. So you can also make it like this, and then you can guide your booking team that, hey, can we add something like if you complete the screenings, you can get your rewards. And for more details about how to activate your reward cards, call us back at, and you add your clinic's number. And patient engagement is better aware because they are already trained, but you are kind of giving them a little bit of guidance on how to do a more strategic booking. So this is what I meant. And this is how we will guide the booking team. So that is a wrap. Okay. I was looking for some scripts that I could share with you, but I was not able to find them. But you understand the point that why guiding the patient engagement team on care gap booking is important. So let's quickly recap on why and how you can guide your booking teams. You can guide them by providing them audited lists, and you must provide them audited care gap lists. When you audit your lists, you are giving them filtered members, and you are able to assign patients to relevant team. You are eliminating uninterested members, right? And the process of elimination helps you to target members strategically. You are not wasting time in reaching out to patients who have already said a no, right? And then secondly, you guide your booking team by informing them about member rewards. You inform them that, hey, do you know Healthfirst has this rewards for this plan? And so can you optimize your scripts or customize them based on this new information that I'm giving you? So members, they will complete screenings when they know that they are getting rewards. And so you will be able to close gaps faster. You are earning incentive, patient is earning incentive, they are also getting reward, everyone is happy. Boom. That's how you close care gaps. And in this 4-part series, all of these 4 steps are extremely important. And that is why we named it How to Actually, because all of these steps are important, starting from auditing, then provider training, all right, then taking the quality meetings, and then finally guiding your booking team. So you see, this is a complete process. And this is how your practice will be able to capture maximum incentive. Maximum incentive.